presentation. My name is Dr. Danielle Miller. I'm an emergency physician and the Medical Education Scholarship Fellow at Stanford's Department of Emergency Medicine. I'm presenting today with Dr. Stephanie Seebach-Sayer, a clinical instructor in Stanford's Department of Emergency Medicine, and Dr. Holly Coretta-Wire, an assistant professor at Stanford. Also, we all conduct competency-based medical education research at the Precision Education and Research Lab at Stanford. And today we're going to be presenting on knowing the tools in your assessment toolkit. We have no financial disclosures. So health professions educators are frequently called upon to assess their trainees and develop new curricula to assess their trainees. Thus, it's not uncommon as educators for us to ask, well, like, what are the best ways to assess our learners? What tools are out there? And just, for all the emergency physicians in the room, like just as you would know all the tools in, say, your airway air kit and know like when you're going to DL with a bougie or use a video laryngoscopy, you should maybe know the tools in your assessment toolkit if you're planning curricula. And I think very few educators receive formal training on types of assessment tools. And the assessment tools in health professions education are as varied as the learners. So from multi-source feedback to multiple choice questions, no single method can do it all. And choosing the right assessment tool in the right context to evaluate learners at their level of training is crucial to providing meaningful assessment of the learner and providing feedback to the learner. Thus, the goal of this session is to provide you with a context or framework for selecting assessment tools, which will be Miller's Pyramid, and also to familiarize you with the common assessment tools through a practical exercise in identifying them, which we'll just do through the chat function. So thus, by the end of the session, you'll be able to demonstrate how to select assessment tools that are tailored to the learner based on the common framework of Miller's Pyramid of Competence. And we're going to do this with 10 minutes at the beginning where I describe Miller's Pyramid of Competence. We'll then complete just a large group exercise that is very low stakes, low key, just where we identify 11 common examples of assessment tools and place them on Miller's Pyramid. And then finally, we'll spend the last 10 minutes for conclusions and any questions. So let's start with Miller's Pyramid or PRISM of clinical competence. And I think like many educational images and pyramids, this is a bit cognitively overloading to process all at once. So let's deconstruct it. All right, so that's better. This is Miller's Pyramid of clinical competence, which was made in the 1990s. This was by the psychologist George Miller, who envisioned competency as this pyramid of actions that are performed. So Miller's ideas strive to define education not by its inputs, but rather by its outputs. So in other words, at the end of a teaching intervention, we're interested in what learners can do, which is not necessarily the same as what we have taught them. So referencing the pyramid, at the lowest level, a learner, knows something, then they know how to do something, then they show you, and ultimately they do or does. And what is important about this does level of the pyramid is that the learner is doing the action or clinical task in a clinical environment or in the workplace, not in a classroom or a simulation lab. So let's do an example. So for example, say you're trying to evaluate a learner on their ability to take a clinical history from a patient, which is a skill a lot of medical students must learn. So a Miller Pyramid of Competence, at the lowest level of the pyramid, a learner may know that taking a history is part of a patient encounter along with other tasks of a clinical encounter, such as performing a physical exam. At the second level, the learner may know how to take a clinical history, which means they can state that taking a history contains many parts, like you take a medical history, a past surgical history, a family history, a social history. At the third level, a learner may show you how to take a history in a structured exercise with a standardized patient. And at the fourth level, a learner just takes a history in the clinical environment. Note again, at this level of does, this is occurring in the actual workplace. So another example for the emergency physicians out there is, say you're trying to assess a learner's ability to place a central venous catheter in a hypotensive patient. At the lowest competency level, a learner knows that a central line must be placed when starting vasopressor. So say your MS3 knows, we probably need to start a central line, and that's the indication. At the second level, say your MS4 sub-I may know how to, and will talk you through the steps of placing a central line. At a third level, maybe a learner can show you how to place a central line on a simulated mannequin. This is your interns at the beginning of intern year. And at the fourth level, a learner just places a central line in a hypotensive patient in the clinical environment, and say that's your second year. So in recent years, the pyramid has found a third dimension of knowledge, attitudes, and skills. In fact, Mayhe et al. In 2009 adapted this Miller's pyramid to include the third dimension, and this is why it's called Miller's prism. So why do we even incorporate these dimensions? Like, why does it matter? So by incorporating knowledge, skills, and attitudes, the pyramid is now incorporating the 3 domains of Bloom's taxonomy. So remember, Bloom's taxonomy is also a hierarchical model used to classify learning objectives and outcomes. You're probably most familiar with Bloom's when you're writing learning objectives and you strive to create learning objectives with words on the top of the pyramid. But both pyramids deal with learner outcomes. As you move up the pyramid, the learner outcomes become more advanced. But what is often overlooked in Bloom's taxonomy is the learning outcomes are in 3 domains, and that's the cognitive domain, the sensory domain, and the affective domain. So taking that central venous line example, in the cognitive domain, you're learning facts, like what is a central line? What are the indications? What are the contraindications? When you learn in like the psychomotor domain, you learn like the physical skills or how to place a central line. And when you learn in the affective or attitude domain, you learn how to empathize maybe with a patient or family who's consenting for a central line. The cognitive domain has been the primary focus of most traditional education assessments, but by including all domains into Miller's prism, it reminds educators that competence and assessment must occur in all three domains. Lastly, as you progress up the pyramid, you move from novice to expert, and these higher levels are thought to have better professional authenticity as they are occurring in the workplace or the clinical environment. So then this finally brings us to assessment in the context of Miller's pyramid. So we have many different assessment tools in medicine to evaluate the learner, and certain tools are better at evaluating whether a learner, knows versus knows how versus shows versus does. And it has been argued that the higher we assess on Miller's pyramid, the more valid the assessment is, and these are more professionally authentic assessments and occurring in the workplace. For example, as an emergency physician, observing someone take a history in the emergency department on shift in their natural working environment may be a more accurate assessment than testing them on how to take a history on a multiple choice exam, for example. So what I want individuals to take away from this session, however, is not that one assessment tool can do everything, and it's important to assess learners in many ways with many tools, and no one tool is necessarily better than others, but some tools are more professionally authentic. And so overall, when designing your curricula or your courses, it's important to think about the level of your learner and what you want the learning output to be on Miller's pyramid, then direct your curriculum intervention and assessment of the curriculum with an assessment tool that is appropriate. This then brings us to our assessment tool exercise. So now we've been introduced to Miller's pyramid, let's move on to identifying common assessment tools through just a large group exercise, and hopefully place some of these assessment tools in your assessment toolkit. So you can see on the left, there's a list of assessment tools, and some may be more familiar to you than others. That's totally okay. That's why you're in this session. This list is not exhaustive, but includes some of the most utilized tools in health professions education. So what we're going to do is identify the 11 assessment tools that are listed on the left as shown in the table and place them on Miller's pyramid as shown on the right. So what I'm going to have you all do is I'll show you an example of an assessment tool, and then I just want you to put in the chat which assessment tool you think it is, and then what level of the pyramid that it's addressing. So for instance, you might say, oh, I think this is case-based learning, and this is showing does. So you would just type in the chat like CBL and does. Stephanie is going to monitor the chat and give us some sort of consensus on what the group thinks. It's okay to be wrong. Like this is just a way for us to see and what tools people are familiar with. And then after we show you the tools, we'll immediately tell you a little bit about how they were developed and when's the best time to use them. All right. I think unless anyone has any questions at this moment about the exercise, I think we can begin. Stephanie, do you see anything in the chat or?
I just asked if everyone's ready because here we go.
Okay, let's do the first one. I'm going to throw an easy example first. So this is example one. Which assessment tool is this and where does it fall on Miller's pyramid? So take a look at it, put your answers in the chat. You have a minute. And this is, again, what the options are.
We're seeing a couple MCQ, no, no's.
Perfect. All right. It honestly, it also might be easier. I'm thinking right about this in the moment to actually take a screenshot of this image so that you have the list of all the potential assessment tools. But yes, this is multiple choice questions. You are all correct. And it's an example of no's. So MCQs fall into the category of no's on Miller's pyramid, though some may argue that higher order MCQs can actually assess clinical decision-making, and thus it can enter kind of knows how component of the pyramid. Remember, there are multiple assessment tools besides MCQs that evaluate a learner's ability to know, including like short answer questions, written essays, true-false questions, extended matching. The advantage of MCQs is that they're generally reliable at testing knowledge and easy to administer, but as tools, they are less ideal at assessing like clinical skills or communication and professionalism. All right, success. We did tool one. Let's move to tool two. This is going to be a little bit more advanced. So take a look. Tell me which assessment tool you think this could possibly be in the chat, and where do you think it falls on Miller's pyramid? I'll give you a minute to look at the tool.
I would say don't feel like you have to know both. If you, let's say, know what the tool is, but don't know where it fits on the pyramid, put in what you know.
And then I'm going to move to the other slide so you can see the options again. We'll give you a few more, 10 more seconds to throw out your thoughts. All right.
Other thoughts or suggestions? We've got one that says OSCE and then one that says shows. Anybody else?
It's okay. These can be hard. This is actually a simulation case, an assessment, and this is shows. So you're correct. And so let's chat a little bit about why this is like a simulation checklist. So notice what I've provided here is a simulation case, but the actual checklist for evaluating the learner is not shown. You can tell this is simulation because it has sections dedicated to like scenario and demographics, goals and objectives, and there's a clinical vignette. You can also see there's the required equipment and moulage on the right. And simulation can be a powerful assessment tool. It allows learners to undertake a specific task in a controlled manner that presents no risk to patients. It also provides a way to clinically assess like when there's rare diagnoses or rare skills, how the learner would perform these. As this exercise is not in the clinical environment, you're correct that this falls into like the shows category of Miller's pyramid. So again, simulation can be a great part of how you assess your learners in your assessment toolkit. All right, so this is going to be our next one. It just keeps getting harder. This is example 3. So tell me which assessment tool this is and your best guess on where it falls into Miller's pyramid. Actually, if you're really astute, this might tell you what it is on the form. I'm just looking at it right now.
Yeah. I figured if we didn't
just,
get any responses, I was gonna like highlight that. There you go.
I changed this one last minute.
We got a mini-CEX, and that means it's a does.
Okay. We're gonna, yeah, we'll, this one I might have, thrown some hints in the actual example. So yes, this is a mini CEX, which is short for mini clinical examination, and it is at the does level. So let's go back to the example. So the mini CEX was first described by the American Board of Internal Medicine as a formative assessment process for faculty to evaluate trainees as they interact with patients. You can see in this example, the assessor must mark which clinical setting the observation is occurring. So making this at the level of does, and you can see that at the top, ambulatory, inpatient, other. The mini CEX was designed to operate in the following sequence. So you do a direct observation of the learner then gives a self-evaluation. Then there's structured faculty-driven written and verbal feedback, which you see in this large open box in the example. And then you develop an action plan for improvement, which you see in this example as agreed action at the bottom. And then you follow up with many mini CEXs throughout the year. The strength of this tool is that it generally takes 15 minutes and can be used in different clinical settings. Additionally, through being observed, undertaking a number of cases over a period of time with a number of different assessors, these individual brief encounters really add up to provide a reliable measure of the trainee's performance. All right, great work. Let's move on to example 4. What assessment tool do you think this is, and where does it fall into Miller's pyramid? And I feel like the students may be more familiar with this than others, though and we'll give you, we'll say 45 seconds.
Yeah. So we have one in the chat for CBL and knows how. Anyone else? We should have mentioned prizes at the end, right, for participation.
It's okay. These are hard examples. So yes, this is specifically PBL, but oftentimes people characterize PBL under case-based learning. So definitely within that context. So this is problem-based learning. Generally, it's assessing knows how. PBL is an approach to learning that is focuses on the dissection and discussion of problems in small groups. Usually it's supervised by one or more expert tutors or instructors. It involves a problem that is laid out in parts as shown here. So you can see like part A and part B, and more information is given about the case and may span many clinical encounters. Generally, students receive a separate information, and then the instructor also has a separate section that helps them promote discussion. I think PBL can be a great formative assessment tool as it assesses the students' abilities to synthesize and integrate foundational concepts. Thus, it falls into like the knows how category of Miller's pyramid. Like I said, some consider PBL to be an offshoot of case-based learning, which we'll talk about in a bit. All right, so I'm going to pass this off to Stephanie, who's going to present the next example.
Perfect. And I just want to because I know we've had some more people come in since we sort of started this exercise. So just what we're doing is we're giving you an assessment instrument, and then we're asking you what type of assessment it is and where you think it falls on Miller's pyramid. Is it a knows how, shows, or does? So This is example 5. Which tool do you think this is, and where would it fall on Miller's pyramid? I'm going to give you just a second to look at this. Certainly been popularized within the context of competence-based medical education.
Give 30 more seconds to take a look.
Can type in the chat.
Yeah, people are typing in the chat. We have DOPS and DOES. I'm going to show the list again.
Okay. So yes, this is the directly observed procedure, and it was developed in the UK, and it involved the direct observation and scoring of performance of the procedures using this 5-point rating scale. So in general, DOP assessments involve an assessor observing the trainee performing some sort of practical procedure within the clinical workplace. And then you've got a structured checklist that is designed to give guidance to the assessors. So there are many forms of directly observed procedures, and the one that we're seeing most often is the OSCE, which yay, go Canada, developed out of Ottawa, the Ottawa Surgical Competency Operating Room Evaluation, and that's the one that you see here. So making sure that the scales also align with the language that we think assessors are using when they're observing these procedures. And so the OSCE is generally a 9-item surgical evaluation tool that is designed to assess the technical competency of surgical trainees using these behavioral anchors, which you can see at the top there. And this does fall into, this falls into the DOES category of Miller's pyramid, because the assessment tool is designed to occur or reflect what's happening in the clinical workplace. And so one of the advantages of this assessment tool is that the trainee is assessed during their everyday workflow when they're performing these procedures on actual patients. And you're not only observing the technical ability, but also communication skills with patients and colleagues. And then finally, you get a range of skills from the simple to more complex procedures that can be assessed within this tool. Let's go to the next one. So what is this tool, and where does it fall on Miller's pyramid? Can we go to the next slide?
Yep. Nothing in the chat right now. Oh, just last minute vote. A last minute vote for OSCE and shows.
Yeah. Awesome, right? We will accept it. So yes, this is an example of something that you might see in one OSCE station. The station box, I think, should have been the hint or the giveaway on this one. And the OSCE was designed to assess performance of learners as they rotate through a series of stations, simulated stations that represent various clinical scenarios. At each station, learners may encounter a standardized patient, a structured oral examination, visual information, or some sort of higher low fidelity simulation task with the trainer. And in this example, it appears that the learner was asked to take the blood pressure of a standardized patient. And so traditionally, if you look at OSCEs, they range from 6 to 15 stations, depending on where you are. And quite often, in my experience, I think has been based upon the space that you have at your institution. And the stations can be anywhere from 8 to 30 minutes per station. And so the actual assessment form for an OSCE can be a standardized checklist, as you've shown here. You can have anchored global ratings and the evaluation of like brief narrative responses. One of the things that I actually find really interesting about OSCE assessments is that if you go back and read Ronald Harden's original paper on what the OSCE was intended to do, he had it that you were supposed to give it to the trainee as they leave and they could take that with them. And, I've never seen that done in sort of recent times, but interesting that would be the idea, that you would walk away with your assessment and be able to reflect upon that. So the advantage of the OSCE is that it generally assesses the shows in Miller's pyramid as the learner is not performing the task in the clinical environment. So that's the difference between the shows and the does. But the disadvantage is that they're time consuming and actually quite expensive to develop and administer.
Perfect.
All right.
All right.
Next one here.
All right, we'll do 30 seconds for this one. All right, so these are the options again. All examples are only used once, so by process of elimination, we're getting closer.
I'd have 5 more pretty unfunctional.
Ooh, someone put logbook, nose.
Yeah. All right, I'm going to take that answer. Yes, so this is the logbooks, and they're structured assess instruments for documenting the learning activities that have taken place. So it could be recording procedures, it could be recording cases or admissions, and things like that. Technically, the logbook as an assessment tool falls in the does category of Miller's pyramid, as these activities are occurring in the clinical environment. And then the disadvantage of logbooks is that they tend to be highly structured, giving very little opportunity for the learner to have input or reflect upon. And also, the learner is the one responsible for usually indicating whether the task or procedure was completed, and there's little room to talk about the quality of that. So maybe you did a particular thing, but we don't know how good it was. So could be a disadvantage.
Perfect. There was a quick question on whether this really nice one integrates into MedHub, and I don't know. I've never seen this used at an institution, but it looks really pretty and would be nice if it just went into our MedHub, but
we're working on it.
All right, so this is example 8.
Remember, things are only used once, so look at what's left on our list.
Yeah, I'll flip to our list.
So what do people think? What is the assessment tool and where is it on Miller's pyramid?
Flip back one more, show it one more time.
Did we get any responses, Dr. Miller?
No responses.
Okay. Well, this one's a tricky one.
I just gave the answer. Oh, someone put it in last minute vote. Case-based learning.
Thank you.
No question mark.
I know you guys are there participating. This is fun. So you can see from our example that the case is presented and then a series of questions are asked. So this tool assesses the knows and the knows how, right? However, what makes this case-based learning and what makes it different from problem-based learning is that problem-based learning is more independent. So it's a self-taught type of learning assessment, and it's generally presented to a group to discuss the problems around the case and decide upon the learning objectives. In simple case-based learning, however, learning objectives and questions surround the case are generally more well-defined. And in our opinion, if you took the knows how piece of Miller's pyramid, you got more granular with the classification. And so Case-based learning is at the bottom section, while problem-based learning would be towards the top as it involves slightly more critical thinking. And case-based learning has been expanded to actually to other assessment tools, not ones we haven't shared here, but a common one being like case-based discussions. And so case-based discussions generally involve a trainee actually presenting cases that they've managed in the clinical environment to their supervisor. And then there's some sort of structured discussion between the trainee and the clinical supervisor about how the clinical case was managed by the trainee. And you talk them through what's occurred, reasons for these actions. And it's designed really to assess the professional judgment or the clinical judgment aspect of the training. And so if you think about case-based discussions as being a little murky in its categorization of the pyramid, it's because on one hand, it's a reflection of what the trainee performs or actually has done in the clinical environment, but it's not actually the assessment of what's happening. And so it's removed from the workplace. So anything with the knows how, shows, between the knows how and the shows is where you can situate this. So long as you're clear about what aspect you're looking at.
Perfect. All right, we're moving on towards the last few examples. I think Holly is going to do 9, 10, and 11.
And you're getting down towards the end, so less things to choose from.
Yes.
So example 9. What do we think this is, and where does it fall in Miller's pyramid?
I'll flip to the options now. We are down to patient surveys, peer assessment tools, also called 360-degree portfolios. And then I'll flip back to the example one more time. We have one vote for a 360 eval, and that's does. Another peer assessment tool, which does the same thing. All right,
I agree.
Yeah.
I agree with that sentiment. So this is a 360-degree assessment, which is also known as a peer assessment or multi-source feedback. Most often, I think you hear about it in the form of multi-source feedback these days, because we're interested in getting feedback from a bunch of different sources and perspectives. So these are generally structured questionnaires that are filled out by a bunch of different stakeholders. And it can be anybody who works with the trainee, meaning peers, supervisors, ancillary staff. So think about nursing, pharmacy, case management, social workers. People have varying perspectives on a learner's performance. In our example, the assessor needs to mark off their position. So the top kind of left corner, whether they're the physician, resident, preceptor, or other. If you specifically are designing tools for a given stakeholder group, you can kind of target your questions toward who your assessor is. These were initially developed actually by industrial organizations in the 1980s, as there was a desire to move away from kind of this top-down single person approach to assessing an individual's performance to get perhaps a more fair and accurate system that offers a multifaceted overview of performance, which is kind of how we think about them, getting a much better picture of what the trainee actually can and cannot do. So how accurate and reliable are these? So they tend to be pretty reliable and accurate in the literature from a bunch of different specialties, much more so where there's training of the assessors. So you can't just kind of hand these to people and be like, go forth and do. You have to do some element of rater training, as bias certainly exists across all different forms of assessors. So disadvantages include the fact that raters are offering their overall perception of the quality of performance rather than a structured performance evaluation. But the strength is that you kind of get an overview of how others view the trainee and his or her work. So it offers kind of an opportunity to compare self-perception with peer perceptions. It's kind of that informed self-assessment of comparing how you kind of view yourself against what other people think. So, all right, 2 left.
I guess the 2 options are patient surveys and portfolios. And here's the example.
also pretty, also doesn't integrate with MedHub. All right, so 1 vote for portfolio and does.
All right, 10 more seconds. Send in your votes.
Feels like an NPR pledge drive.
All right. Answers
So,
are up.
Portfolio, oh, coffee cup, please. Yes, for sure. So portfolio does, yes. So the portfolio is basically a collection of assessment tools. So as you can see in our example, this has a collection of milestone data, case logs, scholarly activities. This falls into does on Miller's pyramid, as it is a collection of achievements of the learner in the workplace. So it's almost like they're showing kind of these different artifacts of, here are the things that I did, here are the assessments I've received from the workplace. It's basically a collection of programmatic assessment. So all the different assessment tools kind of feeding into one place to demonstrate the things that the learner has done in their achievements. The advantage is that it's longitudinal. So it includes kind of the learner creating, gathering, interpreting their own assessment data. Often super helpful if you have coaches who are also looking at performance data, so you can have a conversation around progress, what the trainee needs to do next. And again, kind of going back to that idea of informed self-assessment. So last example.
I'll just provide this one for people to just take a look for 10 seconds, but by process of elimination, we know what this one is, but just so you can see an example of.
If anybody's having a visceral reaction to this, that's okay.
All right, I think that gave a nice sample of what this is.
So patient survey and does. Patient surveys can be used as an assessment tool. So this is specifically Press Ganey. It's the most common patient survey in the United States. For better or worse, we are stuck with it, at least for the time being. Patient surveys can be used, to assess different components of a trainee's practice, most often communication, professionalism, empathy, those kinds of things that from a patient's perspective are more easily assessed, as opposed to, how much did they know? And what exactly, did they manage my case appropriately? The advantage of the tool is that it provides feedback, in domains that we don't necessarily see from a patient perspective typically. The disadvantage, obviously, is that they can be clouded by bias, environmental factors, so many things outside of the provider's control. How long did it take to get their CT today? How long did they sit in the waiting room? Was the person sitting next to them in the waiting room coughing? Like, any of those things are going to color these kinds of assessments. And this occurs in the workplace. Obviously, it falls into the category of does on Miller's pyramid. So has some benefits for, professionalism, communication. We've looked at this in residence specifically, but also has kind of a host of factors that can bias the assessment.
Perfect. And then Stephanie did make a comment that when patients are asked for feedback on trainee performance, they mostly note communication aspects, but they are also able to give a comment on system perspectives such as flow and workload, which is really is very important for the emergency department. All right, so we have finished. Yay, here's a review of all the tools and generally where they fall on Miller's pyramid. So if you want to take a quick screenshot. And so in conclusion, now you have 11 assessment tools in your assessment toolkit. But remember, there are many more. So here's that final image that we deconstructed at the beginning, which hopefully now makes more sense as it's been placed in context with practical examples. In review, you must think of this pyramid when performing instructional design. We should start with identifying our learner outputs for the new curriculum and then identify the appropriate assessment tool for that output on the pyramid. Remember also that the take-home point is not that one assessment tool is superior to another, but rather certain assessments are better at capturing learners at various levels of training and in various contexts. The goal in competency-based medical education is to eventually evaluate learners at that DOES level of the pyramid in the clinical environment, or in other words, we're trying to perform workplace-based assessments. Lastly, for assessment to be useful to competency committees and learners, we need to strive to create learning environments with a series of low stakes but frequent assessment using the tools we've reviewed. All right, with that being said, I'm going to open it up to any questions or comments. Or if Colton, you saw anything in the chat that I missed. If not, the other thing that I might ask the group, especially, you know, we probably have a various levels of learners and faculty and trainees, but I guess what tools have you seen? I guess now that you've seen the tools, like what tools are you using at your institutions? What tools have you found particularly challenging or successful?
Hey, so this is Alex. We tried to implement some more 360 feedback and specifically using nursing evals in terms of communication and that sort of thing. We did a very brief, like at one of the department huddles, like, you know, 5-minute spiel on this is a good way to fill out these evals and this is a not so good example of how to fill out these sort of evals. And we generally get either it's like one or the other, like this resident is awesome and we love them and we hope they stay. And then other just like really horrible comments that probably shouldn't go word for word directly to the trainee. I was wondering what other people experienced in that realm, or if you guys do nursing evals regularly, or how do you do them?
Yeah, I think we can open it up to the group on how they incorporate nursing evaluations or any sort of like peer assessment. I think, like we said, it really does require a lot of rater training for that to be useful and to eliminate a lot of the bias that I think is in the workplace for trainees. But I'm curious if anyone's actually done like specifically for this question, like nurse or even RT or pharmacy, like rater training to help better fill out these like peer assessment tools or 360 feedback.
Yeah, so at Indiana, we've been using nursing assessments for our residents for probably 10 years. About 5 or 6 years ago, it was apparent that some of the comments that you're describing that were not constructive and potentially harmful kind of came to light, and we actually did a study, and it actually showed that there was some bias with female residents getting more of those types of comments. So we did a couple things as sort of an intervention. One was we share a filtered version of the comments and the evaluations as part of our 6-month evaluations with the residents, as opposed to them seeing the unfiltered comments. And so when you get a comment that is clearly not constructive and hurtful, we just take that out. So the resident never sees that. The other thing that we did is we created a rater training for the nurses to review before doing it, that talked about implicit bias and its impact on evaluations, and then gave some examples of helpful feedback and not helpful feedback, et cetera. And we initially then went with a smaller group of nurses that completed this training and then were doing the evaluations, but we had issues with getting enough volume of evaluations on the residents. So we've moved to a little bit more of a different model where we provided that training to all the nurses, and then they actually use a QR code to identify who they want to talk about. The challenge now is I think we're starting to see what you're describing, whereas you have the extremes. You have the people who are doing great, that people want to say are doing great, and then you have the ones that are really struggling as well. Now, we do find them helpful because the nurses will pick up on things that we don't see as faculty. So that's why we've kept it and kind of gone to lengths to try and improve it. So we'll see how things go we've been using this QR code, I think now for about a year. We may have to start incentivizing its use in some way, shape, or form, because it sometimes we don't get as many on every resident anymore.
Yeah, that sounds great. I think our issue is that we've been told before, if we want to teach our nurses anything, we have to pay them because they're unionized and they can't do it on the job. And I haven't figured out how to get over that hurdle.
Yeah, we struggled a little bit, and we were able to work with our nursing management to build it into their whatever training they're required to do. But our nurses are not unionized, so it probably was easier for us to do. But yeah, that's a very interesting difference between the two groups of healthcare professionals.
Well, and sometimes the nursing comments can get filtered through like the program director as well, like, or whoever the attending is. Like, so sometimes we see that happening where the nurse will tell the attending, and then the attending will do like a secure email or something to make sure that the information gets back, but it gets filtered through the attending engineership.
I have a quick question that's a little bit separate, and thanks for the great kind of summary of the different tools that are out there. I think one of the challenges that I find is faculty's attention and their time is pooled in many different directions, and a number of these assessments takes a significant amount of time to complete. How do you balance sort of the quality of the assessment with the need for faculty to be able to stay on task in the department, and and kind of trying to balance sort of all the needs?
Yeah, I think like as emergency physicians, like time is always our, I think as any physician, it's hard to make time for this. And so I think designing like workplace-based assessment tools that are like quick and easy to use is probably the best way to get, like we were saying, high frequency, low stakes assessments. And so I know Holly can probably answer this, but like we recently developed like an app on like a quick, like we're using kind of entrustment scales to quickly evaluate residents on shift. So maybe I'll let Holly pass it over to Holly.
So yeah, coming to an ED near you soon. So we, developed as part of, so in the PI on one of the reimagining residency grants for the AMA, but as part of that, we've developed EPAs for emergency medicine that kind of are in buckets. So transition to residency, the core emergency medicine, transition to practice. And we've used those along with kind of a homegrown amalgamation entrustment scale that kind of fits emergency medicine. It's literally one question. Is which EPA do you want to assess? What is your involvement for the day on the supervision scale? And then narrative comments. So, which we're changing the anchors a little bit, but the question had been, what is one thing they can work on for their next shift? Now it's what went really well today, and what is one goal they should have for their next shift? So really one question to answer and narrative comments. And it is easy, scan the QR code, takes very little time. I think that is exactly how emergency physicians operate. Like if it takes me more than 90 seconds, or I have to go physically go somewhere else or log into something else like MedHub, it'll never happen. So I think, it's making things as approachable as humanly possible. And then really kind of doing like the faculty development, which I think, with competency-based education, it had always been like, oh, it's intuitive, but actually going and saying, here's how you use it. I'm not telling you how to rate people, like document, the truth is somewhere in the middle. I get that, but really, here's how to use it. It's this easy. I think that has been like the key. and it's really simple. You can do it in 90 seconds or less. You can do it at any time on your shift, however it fits into your workflow. And then having super users to be like, here's how I've used it. It's almost like testimonials for like marketing.
Yeah, there's to add to that, Holly, too, is like having multiple sort of entry points. So like some people don't like to write. So there's like a dictation feature within our assessment that Holly's talking about. So if you want to just like talk into your phone and be like, this is what I think about this resident, you can totally do that.
And then I will interpret your dragonisms on the back end.
Perfect. Well, thank you all for the questions and participating. I was informed by Julie that the presentation is recorded, but if you want me to send the examples and slides, probably the easiest way is just to reach out to me. I put my email in the chat, but it's dmiller8@stanford.edu. Great. Well, thank you, everyone. And hopefully you'll use some of these tools.